Hello there and welcome to this tutorial on hemolytic anemia. This is part 1 where I will be giving an overview of the condition.
Disclaimer, this video is aimed at medical students for learning and revision purposes only. For medical advice, seek a qualified clinician. Every effort has been made for the information to be as accurate as possible and in line with the UKMLA specification. However, if you find any errors, please notify in the comments. Note, this video is not sponsored or accredited by the UKMLA, MSc or GMC. Hope you find the tutorials useful. Best wishes.
So what is hemolytic anemia? Etymologically, he means red, lytic means breakdown of, an means without, and emia means blood. Essentially, in hemolytic anemia, red blood cells are broken down earlier than normal, resulting in a shortened lifespan. To compensate for this, the bone marrow increases the rate of red blood cell production. This can increase reticulocyte count in blood test results. Reticulocytes are a precursor of red blood cells, like a teenager version. Note that anemia only occurs when red blood cell destruction is greater than red blood cell production. The hallmarks of active hemolysis are low hemoglobin, because there are fewer red blood cells, so less hemoglobin overall. Raised unconjugated bilirubin, because there's excess red blood cell breakdown, causing excess unconjugated bilirubin, and because the liver enzymes are saturated, they cannot conjugate them quick enough. Another feature is raised lactate dehydrogenase. Lactate dehydrogenase is an enzyme involved in glycolysis and found in high levels inside red blood cells. Excess red blood cells break down and release them into the blood. There will also be raised reticulocytes. Reticulocytes are precursor of red blood cells, which are normally low in blood. Because the bone marrow is producing too many red blood cells, eventually there will be more reticulocytes in the blood. Finally, increased urinary urobilinogen is another feature of active hemolysis. The raised bilirubin is excreted as urobilinogen via the kidneys, and therefore more bilirubin means more urobilinogen. So where can hemolysis occur? It can occur extravascularly, which is the more common type, and it can be physiological, i.e. the breakdown of red blood cells by the reticuloendothelial system, which consists of the liver and the spleen. And this occurs at the end of the red blood cell lifespan. In pathological cases of extravascular hemolysis, there is excess breakdown from the spleen due to multiple causes. Features of extravascular hemolysis include splenomegaly, which is the commonest feature, and hepatomegaly. Intravascular hemolysis is always pathological. Features of intravascular hemolysis includes low haptoglobin, increased methamalbumin, positive urinary hemosiderin, and hemoglobinuria. Now let's understand the reasons for these features in intravascular hemolysis. So firstly, the low haptoglobin occurs because haptoglobin is a protein that binds to free hemoglobin in intravascular hemolysis. An important bus tip to remember is that free hemoglobin is toxic. Increased methalbumin occurs because when haptoglobin decreases, the free hemoglobin is oxidized to methamoglobin. The methamoglobin binds to albumin to form methalbumin. A positive urine hemosiderin is a pathognomic feature of intravascular hemolysis. This is where the renal tubular cells absorb free hemoglobin and store its iron as hemosiderin. Some tubular cells are sloughed into the urine, causing hemosideриnuria. Hemoglobinuria also occurs in intravascular hemolysis because the free hemoglobin that is unbound to haptoglobin and that is not oxidized to methamoglobin are excreted. Now let's look at a way of classifying hemolytic anemia. It can be classified as inherited or acquired. Because this is an overview, we will not be delving deep into the causes of inherited and acquired causes of hemolytic anemia. In inherited causes, these can be subdivided into red blood cell membrane deficiencies, red blood cell enzyme deficiencies, and hemoglobin defects, such as in sickle cell anemia and thalassemia. Acquired hemolytic anemias can be split into immune-mediated and non-immune-mediated. Immune-mediated includes autoimmune hemolytic anemia, which can be warm or cold, alloimmune hemolytic anemia, which can occur in blood transfusion, or hemolytic disease of the newborn. And in non-immune-mediated hemolytic anemia, this can be mechanical, infective, or acquired membrane defects. And examples of mechanical include microangiopathic hemolytic anemia, having metallic prosthetic valves, and infective causes being malaria, and in acquired such as paroxysmal nocturnal hemoglobinuria. So thank you for watching this video. In the next few parts, we'll be delving deeper into these other types of hemolytic anemias.